Hello, welcome to my channel of point of care ultrasound. Today I am going to speak on chest ultrasound, point of care ultrasound in clinical practice in neonatology and in pediatrics. Portable bedside ultrasound is considered as visual stethoscope of 21st century. Uh, it is in fact considered as fifth pillar of examination after inspection, palpation, percussion and auscultation, and now the new term which is come as fifth pillar, that is insonation. In fact, ultrasound is considered as a new stethoscope for neonatologists. In fact, it is added as a super added function for a stethoscope to get more information and clinical data for diagnosis and monitoring of the patients. So the mantra for today is focus for POCUS, and use focus as a fifth pillar of clinical examination. Now let us see this 8-year-old child who came with history of fever for 2 to 3 months off and on, loss of weight for of almost 10% in within 3 months, and this lymph node enlargement in the neck for last 1 month. On clinical examination, this child had hepatosplenomegaly, liver and spleen enlarged. And clinically, the picture was akin to disseminated cocks. The X-ray of the child which was taken showed a opacity in the mid zone and the lower zone with silhouetting of the right side of the heart. And clinically, this was with the clinical picture. The most probable diagnosis was considered was progressive primary complex with disseminated cocks because of the with lymph node cocks. Here you can see the subcostal view, sagittal scan, outlining. You can see the heart beating, below the heart, inferior vena cava entering the heart, and below the diaphragm, the liver. You can just see in the close proximity to the right atrium, a cystic structure with uniform wall with homogeneous echo-free or non-echogenic hypoechoic content, cystic area with a hypoechoic content. So this definitely showed that this is not a progressive primary complex lesion, but it is a cystic lesion close to the heart and most probably a bronchopulmonary cyst. Again, you can clearly see the four-chamber heart wave subcostal area, the liver, and the large cystic area with clean outline with hypoechoic content or anechoic content lying close to the heart. Let us see the second child, a newborn, immediately after birth had a severe respiratory distress, was born prematurely, was not steroided antenatally, was brought to NICU for low saturations and respiratory distress. The first X-ray clearly showed RDS type of picture with ground glass opacification, air bronchograms, and this baby was given 1 dose of surfactant and was put on ventilator. You see the dates below. On 2 consecutive days, in spite of 24 hours, within 24 hours, there is hardly any improvement. In fact, there is worsening of the lungs. So the question which comes to mind, that are you dealing with a hyaline membrane disease respiratory distress, or are you dealing with congenital protein B deficiency, as there is no response to surfactant therapy? The ultrasound probe was put in the suprasternal area uh, to see for the Krebs view, and this is the view which you got on ultrasound. You can see a SVC size almost double the size of aorta and more than the size of main pulmonary artery, and you can see a common chamber with vertical vein going upwards. Compare it with the small box on the top, which is a normal uh, echo picture, and on the color box you can clearly see a red chamber with the blood coming towards the transducer, and it is taking acute turn with the common chamber being connected by a vertical vein and joining the left innominate vein and joining the superior vena cava, showing classical total anomalous pulmonary venous drainage, which was causing the X-ray picture mimicking the RDS or hyaline membrane disease. This is another view which is known as P-sax view or parasternal short axis view. The top picture is showing a normal appearance, whereas here you can see the additional structure lying close to pulmonary artery, left branch of pulmonary artery. You can see the twinkling structure, which is a vertical vein in a cut section, which is normally not seen in a normal baby. Now, coming back to our main point of discussion, is the point of care ultrasound for lung ultrasound. What are the common indications for the lung ultrasound? In neonatology, in all the neonates admitted for respiratory distress, it is used to diagnose the respiratory distress syndrome and quantify the respiratory distress syndrome to know the need to give the surfactant or even to decide about the second dose of administering second dose of surfactant. Any prenatal suspicion of lung lesions, one has to do postnatal ultrasound lung. A third common scenario where we use this point of care ultrasound is neonate with sudden deterioration of respiratory distress. We can see for the complications like collapse, pneumonia, pleural effusion, or pneumothorax causing sudden decompensation and sudden deterioration of respiratory status. Lastly, ultrasound can be used for ultrasound guided procedures like thoracocentesis in a case of pleural effusion or empyema. Coming to the indications of point of care lung ultrasound for follow-up point of care, which commonly is to guide the respiratory support, to determine the need of repeat surfactant, to guide the changes in the level of respiratory support after surfactant delivery. You can decide about hiking the respiratory parameters or lowering the respiratory parameters or deciding what level of PWP you want or for the lung recruitment purposes. It is also used to monitor the progress of respiratory illness to see for the effect of surfactant and improvement in the clinical status. It is done also post procedure to see for the improvement, and in fact it can be used to guide the fluid management by using something called as inferior vena cava diameter or IVC collapsibility or something known as VAXIS or venous access fluid ultrasound. The point of ultrasound, lung ultrasound, is highly sensitive and specific compared to other modalities like X-rays and CT scan. So, in fact, it is the ideal mode to use in neonatology if you want to avoid exposure to radiations by repeated X-rays and exposure to radiation for CT scan. For example, if you take the sensitivity and specificity pattern, it is very high with ultrasound, almost to the tune of 93 to 100% in all common clinical scenarios like, for example, interstitial syndrome, alveolar consolidation, pleural effusion, and pneumothorax. It reaches almost 100% sensitivity with specificity of 96%. What is followed in common pediatric and neonatal practice is something called as blue protocol. This protocol is devised to delineate the fields of the lungs so that you can put your transducer in all those areas in various quadrants. Either you can divide it into 6 quadrants, 8 quadrants, or 12 quadrants according to the area. And the two palms put on the adult thorax shows the top palm shows the upper area of the lung, the lower palm shows the lower area of the lung, and the margin of the lower little finger is the phrenic line. If you go laterally across the nipple line and extend it backwards to the posterior axillary line, we get something known as Plapp's point. This point is very important for estimation for diagnosis of pleural effusion or empyema and estimation of pleural fluid as well as the diaphragmatic movements and to see for the diaphragmatic excursions. Here we see the ultrasound of normal lung. The probe is put in the sagittal section, cutting across the rib spaces. You can see the ribs being highlighted as hyperechoic structures, and since the rib doesn't allow penetration of ultrasound, it gives something called as posterior acoustic shadows. You can see the skin, subcutaneous tissue, intercostal muscle between the ribs, and the pleural line in between the ribs. This pleural line with two ribs adjacent to it gives the appearance of bat's wings. So that's why it's called as bat wing sign. What is important here is if you put it in the video mode, the pleural line slides or moves with respiration. This is called as pleural sliding. And below pleural line causes reverberation artifacts, and it repeats itself at the fixed intervals like a bamboo type of appearance, bamboo sign, or this is called as normal A line. So in normal lung ultrasound, you will get a pleural sliding sign along with A lines equidistant due to reverberation artifacts. So this suggests that the A means air in the lung, and A lines along with pleural sliding use the interpretation that it is a normal aerated lung. Here I am showing you the video picture of the lung ultrasound, normal lung ultrasound. You can see clearly the two rib spaces with bat wing sign, and the shimmering movements of the white line just below the ribs is due to pleural sliding. So this gives the appearance of shimmering movements or ant on a hill climbing the hill type of appearance. Below that you can see the reverberation artifacts. These are called as A lines, horizontal lines, A lines. This suggests the normal aerated lung. Now again, once you get the A lines, you can put the cursor in between the ribs through the lungs, and you get something called as M mode ultrasound picture. And the aerated lung has got appearance which is known as sand on beach appearance. You can see the white line, which is a pleural line. You can see the reverberation or the artifacts caused by skin, muscle, and the pleural line, which gives the appearance of ocean with the skyline. After the pleural line, you get appearance of the sea waves and the sand on the beach appearance due to the lung artifact. So this is called as sand on beach appearance or sandy beach appearance, and this appearance rules out pneumothorax, and it gives the interpretation that you are dealing with a normal lung. Here again, this is a picture from one of the babies from my NICU. You can clearly see the pleural line, a cursor going through the pleural line into the lung, and one can see the sandy beach appearance, which is suggest you are dealing with a normal lung and with no pneumothorax. This is the video of a child with a baby with a pneumothorax. Now here you can see the dense white line between the intercostal spaces is there is no shimmering or no sliding movement. The movements in this line are because the baby is crying and baby is moving, but there is no sliding movement or shimmering movements in that line. And but below that you can clearly see that A line. So one can mistake this as for a normal lung, but normal A line should always be associated with pleural sliding. So if you get a absence of pleural sliding and the A lines due to air between the pleural spaces, this is suggestive of pneumothorax. This is the same baby with pneumothorax. I have put a cursor in through the pleural line and through the lungs, and you can see the barcode appearance, which is totally different from sandy beach appearance. And the barcode appearance on the M mode is suggestive of a pneumothorax and urgent need for putting intercostal drain. Now coming to B lines. B lines are the vertical lines which follow the pleural line. So now at the background you can see the horizontal lines which are called A lines, and there are laser like vertical lines which go for a short distance. These are called as comet tail artifact. They doesn't suggest any pathology and they are normal. Now if you see this in this picture now, the laser like sharp vertical lines which starts from the pleural space go right till the bottom of the screen, and their intensity remains same from top to bottom, and they move with the pleura. As the pleura slides, they also do the searchlight like motions from the top to bottom, maintaining they are hyperechoic. Their intensity remains same. They travel throughout the screen, and they start on the pleura, go downwards, and they move with the pleura. This is the classical distribution of B lines. Up to 1 or 2 B lines per space is normal. If they are more than 3, then they suggest a pathology, either alveolo-interstitial edema or a consolidation or a pulmonary edema in the lungs. If the B lines, which were searchlight lines, they fuse together in 2 consecutive intercostal spaces, then it is called as confluent B lines. So as the degree of severity of pulmonary edema or alveolo-interstitial edema extend from interstitium to alveoli, you get something known as compact B lines. Finally, when all the B lines join together to form something like whiteout area where you cannot see the intercostal spaces or posterior acoustic shadowing behind the ribs, and full area looks white, and such 3 spaces are involved, then we call it a total whiteout of the lung, or something called as compact B lines. Here you can see on the top the hypoechoic ribs. There are 3 rib spaces which are covered by this transducer, and below that you can see a thickened pleura which is irregular, which is hyperechoic, and below that it is all intercostal spaces are fused with B lines, something called as compact B lines, and they are making the appearance of total whiteout below the pleural line. Now one can very well see why it is important. You can get great degree of the pulmonary edema or interstitial edema, and based on that there is something score known as Astor score, that is called as echo-guided surfactant therapy. So you can decide based on the 6 areas, anterior areas of the lung, each lung with 3, upper anterior, lower anterior, and lateral. So 6 areas you scan, and for each area you score from 0 to 3. 0 is normal A lines, 1 is early interstitial edema with more than 3 B lines in more than 2 spaces. 2 is compact B lines or confluent B lines in 3 intercostal spaces with minimal subpleural consolidation, and 3 is total whiteout or compact B lines with more extensive subpleural consolidation. So after that you get a score which starts from 0 till 18. So any score more than 8 is an indication that this baby should receive surfactant therapy. And after giving surfactant, you can, after within 4 to 6 hours, you can repeat the ultrasound to see for the improvement. Or if the score remains more than 7 again, or it keeps on increasing in spite of surfactant, that is indication for repeat surfactant therapy. Here you can see extensive subpleural consolidation. So the score for this, you can give something called this is called as something called as snowflake appearance. You cannot see the posterior shadowing of the ribs, but all spaces you can see irregular or absent irregular pleural line, which is broken into small snowflake-like appearance. This is called as SFS or snowflake sign, which is suggestive of extensive subpleural consolidation. And here you would give assign the score of 3 for this appearance. Now, compared to the previous snowflake sign, the same area you can see the repeat ultrasound after surfactant delivery, and after about 12 hours have lapsed from the surfactant delivery. You can see the pleural line, pleural sliding. You can see the posterior acoustic shadowing behind the ribs, and you can see the normal A lines with pleural sliding. So the lung after surfactant has got aerated and looks normal now. Ultrasound is very useful to differentiate between cardiogenic edema and ARDS. Normally, the lung sliding will be normal in cardiogenic edema, whereas it will be reduced or absent in ARDS. Pleural line will be normal in cardiogenic edema, whereas it will be irregular and thickened and coarse in case of ARDS. The distribution varies. In cardiogenic edema, it is homogeneous opacification or distribution spread from posterior lateral to anterior area, whereas in ARDS, you will get spread areas. So normal areas with normal pleura in A lines and no B lines, and some areas with subpleural consolidation and severe B lines. There will be consolidation in cases of ARDS, subpleural, and there will be no consolidation in cases of cardiogenic edema. And finally, a pleural effusion is more common in cardiogenic pulmonary edema, and it is less common in ARDS. So it helps to differentiate ARDS from cardiogenic pulmonary edema. In this clip, you can clearly see to your right, A lines with pleural sliding, normal lung, and adjacent to it, in the next intercostal space, you can see irregular pleural line or cut-off pleural line with subpleural consolidation, which looks hypoechoic with irregular edges, and below it are total confluent B lines. So it is a subpleural consolidation with adjacent normal lung. So this is called as spared areas. In this video clip, you can clearly see the liver with portal tracts inside. You can see the diaphragm, and just at the base of the lung, you can see a shredded area with irregular borders with snowflake-like appearance, and this is called as a shred sign of consolidation. So there is a lower zone consolidation or pneumonia, and in the upper spaces you can see the confluent B line. So this is a case of basal consolidation just above the diaphragm. Image qualities are so good. Here in video clips, you can see the parietal pleura, visceral pleura, and you can see the anechoic space between these. So if you draw a line from one roof to another and then two horizontal line between the two pleura, you get something known as quad sign, which is a sign of pleural effusion. You can measure the distance between these two lines. And if it is more than 1.5 centimeters, that means there is some significant pleural effusion or collection in the pleural space, and you will require to put in a needle to drain this fluid out. If it is less than 1.5, you can take it as, and if it is a clear, you can take it as a syn pneumonic effusion. And once you treat the pneumonia, it will disappear on its own. But if it is turbid, if there are floaters inside, it is known as plankton sign. Or if there are fibrinous exudates or floating exudates or fibrinous strands or septae inside, it suggests that it is a complicated pneumonia or a empyema, and one will have to put an intercostal drain to drain that pus out. Another sign is by putting a M mode cursor through the intercostal space or through the effusion, and you get a effusion area, a wavy outline. Now this is called as sinusoid sign, which is suggestive of pleural effusion. In this lateral flank approach, sagittally, the orientation of probe is with the sagittal marker or lateral flank coronal scan. You can see the dome of diaphragm. You can see the lever below the diaphragm, and at the right at the back, you can see the spinous bodies of the spine. Normally, the spine should cut off at the level of insertion of diaphragm, and the top part of the spine should not be seen. The last piece of the spine which should be seen is at the level of the insertion of the diaphragm. Herein you can see the vertebral body above the insertion of diaphragm. This suggests that there is a collection in the pleural space which is allowing the ultrasound waves to travel and highlight the vertebral bodies at the back of the lungs. So this is a sign of pleural effusion. So this is called as a spine sign of pleural effusion. Another sonographic sign of pneumonia is something called a shred sign. In this picture, you can clearly see it gives a shredded paper appearance with snowflakes like shredding with irregular margins, and there is no actual line of differentiation between normal lung and the shredded areas of the lung, and you get a punched out areas inside hypoechoic areas which are suggestive of consolidated or pneumonia in the lung. Here in this video, you can clearly see the shred sign of consolidation, snowflake sign, as well as compact B lines. And on the lower end, whatever is seen is a lever. Putting a color Doppler on that area helps one to decide whether there is a collapse or consolidation. You can see here tree-like branching ramified appearance of the hypervascularity of that area, which suggests that it is a consolidation. Now let us see in this picture, whatever is below the diaphragm is a lever. You can see the appearance of lever with ported tracts inside. Above the diaphragm, you are getting hypoechoic area or anechoic area, which is a pleural effusion. And you can see the floating debris, sand-like debris in the pleural effusion with the strands, fibrinous septae or strands. So this is a clear cut that already pus has formed in this effusion. So it is not a simple effusion, it has turned into pus, and it is an empyema or a complicated effusion. On top of this effusion, you see a consolidated lung. You can see this lung almost looking like a liver. So this is called as red hepatization or hepatized lung. The lung assumes a solid appearance like a liver and it looks almost like a liver. So this is called as red hepatization, which is a sign of pneumonia. And inside this lung, you can see these parallel lines, white lines in the mid zone and the lower zone. These parallel white lines are the air in the bronchus, highlighted because of the surrounding consolidation. So it is called as sonographic air bronchograms. So sonographic air bronchograms with red hepatization of lung clearly gives you the diagnosis of pneumonia. So this is a complicated pneumonia, and you can see some lower portions, some hypoechoic areas in the consolidated lung. So these are areas of necrosis. So this is a severe necrotizing pneumonia, which has got a high mortality and high complication rate with purulent empyema. So this baby was admitted in intensive care Almost 1 liter of pus was drained from the chest. What is important in ultrasound is that you target not one organ. When you are targeting one organ, if you have ancillary information, you can get other findings which you have to keep in mind. For example, in this child with complicated pneumonia with empyema, if you look at the liver, just below the liver, you can see a structure which is a kidney. Normally, kidney is hypoechoic compared to the liver. Whereas in this clip, you can see the echogenicity of kidney is almost equal to that of liver. So here, this child, you can know, is a severe case because of the sepsis. His kidneys also are involved, and he has got acute kidney injury. The same child, severe necrotizing pneumonia, severe empyema, acute kidney injury. Simultaneously, other organ which was screened was liver. This child went into a toxic ileus. He went into paralytic ileus, and you can clearly see here the liver looks studded with snow-like pattern. So, liver has become echogenic because of the air trapped into the portal radicals, and you can see the portal vein, right portal vein, and going upwards is the left portal vein. You can see the air bubbles moving inside the right and left portal vein. So this is called as gas in the portal vein, and this is a bad sign or ominous sign. This baby was brought with respiratory distress after birth, with low saturations and with differential saturations of more than 15% between the right upper limb and left lower limb. And clearly the child had PPH, but the ultrasound was done, and you can clearly see here there is a break in the diaphragm. You can see the left kidney almost reaching to the level of the heart. You can see the fluid collection next to the heart. You can see the bowel loops with peristalsis lying close to this kidney. So this baby had a congenital diaphragmatic hernia, gap in the diaphragm, through which the kidneys and the intestine had herniated into the left thoracic cavity lying close to the heart, pushing the heart on the opposite side and causing severe distress. The child baby was diagnosed as congenital diaphragmatic hernia. This is the X-ray of the skin, same baby. You can see the loops of the intestine into the lungs. In fact, this baby had everything into the thoracic cavity: stomach, spleen, kidney, and intestines into the thoracic cavity. This is the same child. You can see the left lobe of liver, fluid, bowel loops, stomach, and spleen into the left thoracic cavity. A case of congenital diaphragmatic hernia detected on ultrasound.
Here one can see the herniation of spleen, left lobe of liver, and stomach and bowel into the left hemithorax because of the congenital diaphragmatic hernia.
A 3-month-old baby who presented like a bronchiolitis, and this was the X-ray, and you can clearly see the triangular patch of opacification into the right upper lobe. It was thought to be uh, query consolidation pneumonia. In this picture, you can clearly see the suprasternal notch, the probe was put. You can see the aorta, main pulmonary artery, branches of aorta. So this is because of the suprasternal notch vessels. And you can clearly see lines, starry sky appearance structure lying above these blood vessels with clear-cut capsule and margins and homogeneous appearance. So this was the case of enlarged thymus, which was casting the shadow and giving a appearance of pneumonia. The same baby in sagittal scan, you can see the thymus encasing the heart, but at the same time, you can see few of these empty air bronchograms into the lower areas. So this child actually had a thymic enlargement and mucus plugging, causing collapse of the lung and causing air bronchograms due to collapse, small atelectasis or collapse. You can see the X-ray of another small baby. It gives appearance there is a mediastinal mass and heart being shifted towards the left side, mediastinal mass. On the X-ray, whereas once the probe of ultrasound is put, one realizes it is a huge thymus which is extending right up to the lower border of the heart. So it is a huge thymic enlargement. You can see right coming right to the apex of the heart and encasing the heart. So it was a huge thymic enlargement which was mimicking the widening of mediastinum due to mass. This is the X-ray of the same baby with the outlining of the thymus. So it was a thymic enlargement mimicking mediastinal widening and a mass. Finally, the ultrasound is very, very important in NICU. When the baby suddenly who is on the ventilator, you are treating the baby, and the baby all of a sudden, without any reason, collapses, starts desaturating, goes into bradycardia, hypotension, shock, or acute collapse, or deterioration or worsening, and you have various different possibilities. So this is something called as SAFE protocol. SAFE is sonographic assessment for emergency, and R is for revise. So this protocol is specially revise protocol. So you initially you put the probe, cardiac probe, to target for echocardiography. You see for the myocardial dysfunction. If myocardial contractility or dysfunction you get, you ask for the cardiologist to rule out CHD, and you take the opinion on the echocardiogram. If myocardial function is okay, but the patient is still bad, then you rule out the cardiac tamponade by doing a subcostal 4-chamber view for pericardial effusion and see for tamponade signs. If there is a sign of tamponade, immediately you put in a needle and aspirate, and the baby improves. If there is no tamponade, then you go in for pathology in the lungs, see for the A lines and lung sliding. If lung sliding is present, pneumothorax is ruled out. If lung sliding is absent, then it's still considered pneumothorax. If lung sliding is absent with only A lines or B lines, if B lines is present with lung sliding, then again the pneumothorax is ruled out. But if there are no B lines and only A lines, then pneumothorax is on the card. Then you see for the lung point, the point between the normal lung and the pneumothorax lung, where there is point of junction between pleural sliding and absent pleural sliding and present pleural sliding. If you get a lung point, then pneumothorax is confirmed. You put in a needle and drain the air. If the lung point is not there, and then you have to think of alternative diagnosis and other causes. Other causes could be effusion. If there is a effusion, signs of pleural effusion, you put in a needle and aspirate the effusion and the baby improves. If there is no effusion, no pneumothorax, contractility is good, there is no pericardial effusion or tamponade, then you shift on to look out for congenital heart disease. You see for the pulsatile pulmonary aorta, pulsatile abdominal aorta. If the aorta is pulsatile, then you have almost ruled out critical aortic stenosis, or you have ruled out thrombus of the aorta or coarctation of aorta. If aorta is pulsatile, then you ruled out critical cardiac lesions. Then you look out for abdomen, for any abdominal perforation, either intestinal perforation or extravasation of TPN or hemoperitoneum. If the fluid is there, accordingly you target your management. If there is no fluid in the abdomen, then you shift your probe towards the head and look for the brain. If there is intraventricular hemorrhage, you give the needful supportive measures. If there is no intraventricular hemorrhage or brain hemorrhage, then you look out for the other causes. You further investigate for congenital heart disease or take an expert opinion echo to rule out congenital heart disease. So this is a safe protocol which is very helpful in managing a crashing neonate in NICU. Thank you very much. Thank you for your attention, and I hope I will bring out more such videos for role of focus in management in NICU and general pediatrics OPD. Thank you. Good night.